And then Rose Costello is going to do the coding and billing lecture, and we will also provide a copy of that lecture as well. During at one time, we'll make you an expert in coding, right, Cathy?
Right.
It takes years, so don't get frustrated with it. Just realize it's a process. Okay. Well, Rose is here. I'll look through anybody's table. If anybody gave a table for you, give some feedback. If you haven't given that to me, give it to me now. Or right now, it's too late. And then I'm going to talk just a little bit about your models. And I've given you some examples through the course tonight and then a few additional items I put in the course. Okay? Everybody surviving? Barely? Okay. Cathy, tell them a little bit about yourself and tell them the great news you just shared with me.
Thanks, Janet. Hi, everyone. I really enjoy coming back up here. I actually grew up less than 5 miles from here, down around John Carroll. And so every year it comes up, it gives me a place to set as to how things are going and what we do, because I can think of the time every single year. And what Janet is referring to is back 8 or 9 years ago when electronic health records were really first coming in, because it was a time that the government was paying hospitals and physicians $34 billion to put them in. We started working together, and back then we were referring to everything in the future. This is what can happen. This is what we think will happen. And the reality is, here we are, less than 10 years later, and it is just amazing what's going on. So it's fun to share with everyone. But if you all wouldn't mind, before we get going, it always helps me to know where you're from and what you do. And just give me your first name, and if you're like at the clinic or UH or Lake or Metro or something, if you're in a certain department. And if you're not working, that's fine. We've all been not working too, and going to school. Or if you're in a private practice, let me know that, because then when I refer to stuff, I can talk about your specific situation. And what we'll do is go from the policy side of things to what the government's asking people to report on, to talking about what happens in Ohio, and then actually doing a demo. So by knowing what you all are interested in, we can kind of run through that. So if you wouldn't mind, can we start back there?
Anise, University Emergency.
Perfect.
Kimberly, University Emergency Department.
Okay.
Robin, I'm at UH and Cleveland Clinic in radiology.
Okay.
Maljeet Kumar, work at Metro Skilled Nursing.
Oh, good. Okay.
Shannon, I'm at the clinic and at Ortho.
And then Jennifer, I'm in healthcare, but I'm not currently working.
That's I'll talk about that in a minute, but go on.
Mariana, I work at the clinic at the short stay unit.
Okay.
Tom, UH Healthcare.
Perfect.
Paula, and I work at the skilled facility, Mejia.
Alicia, I work at UH.
Okay.
Ebony, I work outpatient liver care.
Okay.
Brittany, I work at the clinic emergency room at Grassroots.
Leon, I'm clinic group 12.
I'm Stephanie, I work at Health STD.
And where?
Hillcrest Emergency Department.
Okay.
Yeah, I'm in the clinic oncology.
Dave, I work at University Hospital and GIG.
Lisa, I work at Metro Labor and Delivery.
Ashley, I work at Focus and Labor and Delivery.
Allie, I work at the Blue Clinic and cardiographic recovery.
Kelly, I'm working in invasive cardiology at Heritage.
Carolyn, I'm at Metro and short stay right now. Katie, I'm private practice.
Private practice, pardon?
Yeah.
Okay.
Tanya, I work at Metro, and I work in family practice, Crash Express.
Rockwell, I'm at Metro, family practice, Express.
And I work at Southwest General Hospital at cardiac step down.
Okay.
Michael, I work at the VA long-term care.
Oh, good. I'm glad the VA's here. Okay.
I'm Kelly, I work at the Clinic Emergency Department.
I'm Cathy, I work at the Cleveland Clinic under the Ursuline unit.
And Hannah, I work at Cleveland Clinic in cardiology.
Wow, did I miss anyone? Oh,
Actually, I work at UH, I'll be high-risk GYN surgery.
Okay. I am thrilled at the cross-section that you all bring because I've heard every area that we work with. And it's going to be fun to see how it all flows together. But I like the person over here said they were at the integrated care. Who was that? Yeah, when you talk about integrated care, what exactly are you doing?
I coordinate services for psych and primary care.
Perfect, we'll talk about that, because that's on the first slides. Anyway, to tell you a little bit about me and a little bit about our organization, and you may well know our organization under a different name, but as Janet said, I'm Cathy Costello. I started this position back when the Ohio Health Information Partnership started 10 years ago, when the hospitals, the two big physician groups, the osteopaths and the OSMA, the state of Ohio and the state of Ohio's high-tech arm all got together and decided to kind of pool resources to try to draw down federal dollars to support the adoption of electronic health records in the state and to create a network to connect everybody. Because as we know, at that time, and it's still true, that Cleveland Clinic, which is on Epic, and UH, which is on Allscripts, had no way of connecting. And honestly, that particular example, I heard more than once nationally. Oh, in Ohio, nobody ever talks to each other electronically. And it's like, well, we can certainly say that is not true anymore. But that's the reality. That's what they were trying to do. And we ended up bringing in more than $50 million into the state to support the adoption of electronic health records and to create this network. And so the network is now called CliniSync. I don't know if any of you have heard that, but practically everybody in the room works with CliniSync. Your organizations do. But what makes us successful is that you don't have to know that. We connect you behind the scenes. We bring you all this functionality, but you don't have to go outside your EHR to pull in records from another source. And so that's really what we consider being successful, is that we can bring data to you for your patient care management, and yet not make it so cumbersome on you to retrieve that. Think of what it was even 5 years ago to have to get paper records, from another site, from another hospital. The VA was always an interesting one. I don't know if this is still true, but when we first started working with the VA, we were told that in order to do documentation on a claim that needed further documentation, that the VA, at least the one in Chillicothe, had a policy that they could not mail records and they weren't doing electronic, and so they had a driver who would drive all over the state to pick up documents. Is that true? Am I telling the truth?
I heard stories about how hard it is to get things from the VA, but I don't know if it's exactly.
Okay, well, trust me, they were so thrilled when we showed them how they could email electronically in a HIPAA secure way. It was like, oh my God. And the VA was like, well, the hospitals were like, we went from 90 days claims payment time to 2 days, because we set them all up with an electronic network, and they were like, oh, this is wonderful. But anyway, so let's go back though and talk a little bit about what's going on at the national level, because I think that's one thing. You all have so much to bring to the discussion in healthcare nationally. There is so much going on, and there is no question that the role of advanced nurses is one of the critical components for the whole workflow that's going on nationally. Pardon? Yeah, I think I'm recording. As I said, our group was originally founded, as I said, by the four groups, Ohio, the hospitals, and the two big physician groups. We are a not-for-profit. We are every state in the country received funding to set up these networks, which are called health information exchanges. But I would say only about between 10 and 20% of them have been successful, because at the time that that funding was released to the states, if you remember, we had a major recession going on. And so the states that left the HIE within the state structure usually took the funding, and although they had to use it to set up the HIE, there was no ongoing sustainable business model. And so as they used up the grant funding, a good number of those HIEs are not really working to the full capacity because they just were not funded on an ongoing basis. In our case, because we were set up as a private not-for-profit, it required us to become sustainable as the grants closed. We brought up 6,000 physicians and nurse practitioners, dentists on electronic records. We worked through the hospitals and with other groups to do that, but we were the largest group implemented in the country, and we now have 155 or 156 hospitals all part of the network too. So it's a pretty large network. And we maintain that private not-for-profit structure. We have all these various groups, including behavioral health, as part of our board. And we have an advisory council that kind of looks at upcoming policies and figures out how we can make the health information exchange work for example, integrated care, behavioral health, all this stuff. Long-term care is a huge part of our picture right now. So I'll talk about that as we get to what's going on at the state level. But let's talk about the federal priorities. I'm sure you follow some of this in the newspaper, but in breaking it down specifically, there are several big things that CMS is doing right now. They are creating a network that is supposed to make the records interoperable at the national level. Like right now, we are the largest HIE in the country, but we are basically a regional operation. And what CMS is trying to do is to take this whole picture to the national level so that we can exchange records with, for example, Florida. Think of how many snowbirds you all have that need care. And if it's not staying within the Cleveland Clinic system, for example, when they go down to Florida, then you're kind of challenged sometimes to get those records. So there's different ways you can do that, but what CMS is trying to do is to create that national structure that's going to allow that information to flow more easily. It is really a challenge. They're just at the beginning of the process, and two of the things that are challenging about it is it requires data governance. It took us a whole lot longer to set up the policies to set up an HIE than it did to technically integrate, because the technical integration was pretty cut and dried. You knew what to tell the hospitals to do when you were working with them, but it's the data governance that can be challenging. So when you're talking about trying to set up some type of network over all 50 states, it's going to take a little while until they set up all the policies and everything. So that's number one. But the second thing, and you all deal in healthcare, so you know what the problem is, and that is consent. Every state has a different take on the consent that's necessary and the types of records that can be held back from release. The HIPAA standard is the most common one now, thank goodness. It's over the past 10 years, more and more states are adopting HIPAA. The whole idea is to use the same standards for release of data and the same protections that HIPAA brings, and if everyone worked under that standard. But not every state does. There are still about, I'm going to say 15 states that don't use HIPAA. They have their own little separate release for example, behavioral health records. Drug and alcohol is a whole nother area because of federal regulation in that area. But again, this is just a problem that has to be addressed, but they're working on it. So that's number one. There's new data standards that are giving expanded information You know, the things that were exchangeable in the first wave, when we first started exchanging data, you know, like 5 years ago, were meds, med allergies, problem list, and patient demographics. And now, each time they put out new data standards, you see them looking for more information that's going to make it meaningful for that care coordination. And this set of data standards has more information on care planning that's supposed to flow into what we call the continuity of care document, or CCD, which is your summary of care that you produce after a visit, after an ED, discharge, after inpatient, after you've been to the doctor. And so you'll see new data standards with more information there. And then the last thing that is a big priority right now is something called information blocking. It is not a problem in this state, trust me, because we have so many hospitals, so many practices, we have thousands of physicians contributing to the electronic health record, HIE, that you don't really see information blocking between organizations as an issue in Ohio, but you have to think of the other place where you have to think of it as these new regs come in is to make sure that you're making data accessible to the patient. Huge priority for CMS right now, data access by the patient. What we're seeing, and for those of you who have worked in healthcare for a while, you probably remember about 5 years ago, we had this big push going on to have patient portals. Remember that? I mean, obviously Epic is one of the first and oldest ones to have that kind of robust patient portal. But for many of the vendors, the timing of having a patient portal was linked to the requirement for when you had to report it back to the CMS in order to get your reimbursement for doing the work. And that was 2014. And so in 2014, you had all these little physician offices, all these hospitals that had never had portals before, were trying to bring them up, and you were supposed to have a strategy around how to access that. And that made it just, shall we say, interesting, challenging. As it goes over the past 5 years, and certainly with Epic leading the way, you had more and more robust portals, and that's not so much an issue right now. You do have issues, for example, in the long-term care area. Do you use point-click care?
Yes.
Okay. Point-click care is the biggest long-term care provider, and I'll talk about that in a minute, but they've come a long way in the past 5 years on their capability too. But the reality is CMS is like, well, we don't think that, okay, yes, you've made the data available now, but we don't think it's usable for patients. We want it to be really accessible. So what's really accessible in this day and age? Having it on your phone. So this is what this year's wave is the new requirements technology-wise is that every hospital, every practice that is reporting to CMS is required to have what we call an API, and I'll talk about that in a minute. But it's the technology that allows you to push data, in this case, to the phone. I mean, you can push to a lot of different places, but that's what the whole idea is. They want, say you have a patient who goes to 5 different practices, specialties, hospitals, you know, as we all have. Very seldom do people have this one provider, you know. And their thinking is, if we had some way of gathering all that data together and giving it to the patient, that would be great. And if for those of you who have iPhones, you can actually look at that health data section. That is exactly what they're talking about. I don't have my phone out, but you can see it on, if you look on your iPhone, there's something called health data, and the amount of data that you see on that depends on how many of your providers are hooked up to that. But that's only one. I mean, Apple was the one who pushed this really hard with the federal government. They're like, hey, we can do this. This is no problem. But the reality is we're in the middle of the technology that's going to be needed for that. So these are big priorities, huge priorities for CMS, is patient access to their records. The other thing, and I know I talked about this last year, but I can't emphasize it enough, is care coordination. That's why I was asking about the integration piece. And for many of you, so home health, long-term care, many of you are in the hospital setting, so you know what I'm talking about when I say CMS is watching readmissions. I mean, that is like one of the biggest metrics, and it's not just a plus metric, it's a minus metric, and everybody gets judged on it. It used to just be the hospitals were getting a -3% if their readmission rate wasn't below the national average. Well, the reality is now, physicians, nurse practitioners, anybody who reports individually or as part of a group practice will have a readmission figure as part of their quality metrics. The long-term care area has readmission rates that they are judged on. Actually, step-down home health now also has, they're linked to the long-term care area. So this is a huge thing. And what CMS is saying is we want better care coordination in order to prevent people from ending up back in the emergency room or being readmitted. And in order to do this, they're saying you have to have more of a plan about how you're going to coordinate. Now, the technology I can tell you about, but honestly, we're working a lot with a lot of different, not just organizations, but communities on their care coordination. And I'm sure you all have heard this, but the social determinants of health, transportation, food, stuff like Meals on Wheels, social services are just huge, huge, huge now. There's a recognition that you can handle the clinical side, but in a lot of cases, it's the social side that determines how this person's outcome is going to be affected. And so in the area of behavioral health and primary care, that is probably one of the biggest linkages you see right now. And so what we're seeing is hospitals actually embedding social workers and nurse practitioners into their emergency room to work with these behavioral health cases that come in and to make sure that they are linked to a primary care site that can actually provide ongoing care. Drug and alcohol, another huge area, another big priority, as you all know. I mean, we all live in Ohio, so I mean, we've been, between us and West Virginia, we've been about as beat up as any states on the question of opiate addiction and, problems and, the whole problem with fentanyl and stuff. We're actually working with the state right now, the Ohio Department of Health, to help them improve their data reporting around drug overdoses so that there's a better understanding of exactly how that's working. But at the national level, this is an area, this is tricky. For those of you who work in, I know several of you said that you're doing behavioral health, but I don't know, are any of you involved at all in SUD, drug and alcohol? No, okay. The reason I'm bringing this up is drug and alcohol records flow differently than the rest of the records. The rest of the records, including behavioral health, flow under the HIPAA standard, which is basic. You protect the patient's record, protect it for treatment. It can be used for treatment. It can be used for payment. It can be used for operations, but it's not generally available beyond that. Well, when you're talking about drug and alcohol records, much higher standard. It's what we call 42 CFR Part 2 is the technical term. People refer to it as Part 2. And the difference between that and HIPAA is like, if you needed records to take care of a patient, you could go to our system or you could get those records under HIPAA, which is fine. But if you're talking drug and alcohol, you have to have individual consent from the patient every time you want to transfer those records. And so it's much more cumbersome, and think quite a few of you are in the AD setting. think about that question of having to get that individual consent, you know, and make that accessible. Even though in an emergency situation, drug and alcohol records are supposed to be generally available to an ED setting, the reality is they're very hard to come by. And so CMS is trying to rethink the whole area because this requires a change by Congress as opposed to just a regulatory change to make drug and alcohol records under HIPAA standards. And they tried to do that last year. They had a huge, what we call omnibus piece of legislation. They combined 26 bills at the congressional level involving opiate treatment. And we thought that they were going to change that standard at that time, but they did not. So that still remains, part 2 still remains a real challenge on getting the full picture when you're trying to treat a patient. Just before we get off of opiates, I just say one thing. This is up and coming. It's something you don't, there's nothing for anybody to do other than just to be aware of it. But there are just millions, if not billions of dollars flowing right now under drug and alcohol grants. Ohio has, we know one FQHC, the Federally Qualified Health Centers in Southern Ohio, that by itself is pulling in like $4.5 million to create a network of treatment in conjunction with the schools down there and primary care. So this is a huge area. Ohio Medicaid is looking at a new line of grants that would also be linked to payment that would be for children at risk from the ages of 0 to 21 and would include drug and alcohol and other high-risk areas. This is called the INC program, and so Medicaid is just bidding on that right now. But for those of you who have any interface with pediatrics, you'll probably hear more about this over the next several months. Okay, new technology and things that CMS is trying to get done based upon their technology reporting. The first thing is they expanded. This is a big year. Like every 3 years or so, they upgrade the standards for what needs to be in the electronic health record, so it makes it more robust. And this is the year that that new standard, which is called 2015 edition, is coming in. Everyone that I heard from, I'm not sure about the independent GI group, but everybody else, you're already on 2015 edition. And what that means is it gives more, as I said, like the care coordination information is part of that. The next thing is e-prescribing of controlled substances. This is something that is linked to the whole effort to get a handle on opiate addiction. CMS is going to give hospitals and practices bonuses if they have that implemented this year, but either way they have to do it by 2020. And e-prescribing of controlled substances from a technical viewpoint is, as it says, it's using your technology to do this specific type of prescribing. And the difference between that and regular e-prescribing is there's an additional layer of security and identity proofing that goes with it. It is more costly to put it in than straight e-prescribing, but everyone in this room, you either are implemented or you will be by the end of the year. I think Cleveland Clinic's doing it later in the summer. I can't remember what UH's time is, but it's basically something everyone will have to do if you're going to be doing any type of e-prescribing. Query and retrieve is new technology that really involves groups like ours that provide outside records for you. So your system needs to be able, right now, everyone's EHR systems can report out for information that you have gathered on a patient within your system. You create what we call the CCD, the Continuity of Care document, and you push that out to whoever needs to get it, to the long-term care site, or to home health, or to another hospital, or whoever your primary care. That's called the outbound. What they are putting into effect this year is the inbound. You need to be able to query an outside source to look for information on that patient and then bring it into your system. So it's completing the loop about that patient's information. On the one hand, you're pushing out information that will be followed up by the next treating provider, and you are bringing in information so that you're not either repeating testing, or you can see what the patient's history is. And we're actually going to look at that live in a few minutes. The next area is the API functionality, and we did talk about that for the phone apps, and CMS is all over use of APIs, and when you hear that, it's just a different way of pushing data. CCDs have a certain structured number of fields. I mean, that you can go down, it's like 10 or 12 different fields that are incorporated into a continuity of care document. It's just a technical architecture so that everybody in the country's EHRs are speaking the same language. That's what all CCD is. The API is a less structured form and can be used for many different purposes. And so you can, rather than pushing this big continuity of care document every time, an API is more directed. And so you'll see it over the next couple of years being used for different types of exchange of data. And then the last thing is, and some of the folks who are in the GI area and some of the other areas, you probably have already heard about this, but it's called the AUC initiative, Appropriate Use Criteria. And this is an area that goes to scans and imaging. And what CMS is requiring by January is, I'm sure you all have heard about the problems with getting prior authorization. So pre-auth from a payer. If you haven't had to do it in the professional area, I'm sure you have personally, and it can be quite challenging. Well, what the AUC initiative is guidelines were set up over the past 6 or 7 years by radiologists and payers, and all these groups came together and set up criteria that could electronically review information about the patient's diagnosis and problem list and everything else, and then approve electronically or make recommendations for another type of scan. So, with and without contrast, or CAT scan versus MRI. And so this is coming in this year, at the end of this year, and it's just going to, everyone who does any imaging ordering is going to be affected by this, either the ordering provider or the receiving provider. And in about a year, if you have to have that technology in place, or it will affect your payment. Right now, it does not affect the payment. You just need to be able to start doing it. CMS, remember how I said that CMS paid like $34 billion for people to get on electronic health records? Now they're creating bonuses, incentives, and disincentives for you to basically report quality and to report that you're using your technology correctly. And the bonuses started out like at 3%, 4%. Well, and by next year, you're up to 9% bonus or minus. So it's really important that people understand what the reporting requirements are. And for the most part, it's stuff we just talked about. It used to be, when we started that whole meaningful use process 8 or 9 years ago, you had to report on like 26 or 27 different measures. It was painful. You'd have to report a numerator and denominator. And I mean, it's like really, for those of you who did it, you can remember this. You had to report on, did you collect patient information? Did you collect vitals? Did you collect demographics? Did you order through an electronic health record system? Did you send stuff electronically for prescriptions? It's all stuff that went to the functionality, but it was really painful to report. I mean, let me tell you, it was not good. Well, as CMS has gotten down the road and so many more providers are on electronic health record, it was really viewed as being just nitpicky. And so they said, okay, this year we're going to move away from all this, reporting of numerator and denominator. We're going to get serious about what our priorities are. And their priorities are privacy and security, always top of the list. Everyone has to do a privacy and security review every year. E-prescribing, in just a second we'll come back to that. That health information exchange, the pushing and receiving of data, the patient access, which we just talked about, and the public health reporting, which is your immunizations and your syndromic surveillance, and then if you're doing any specialty work. What CMS has done is they've assigned points to each one of those categories, but the points tell you how important they view it. So your two biggest areas that get points are the patient access area, so they're really intent that patients have complete access, and the pushing and receiving of data. As far as e-prescribing, I told you that e-prescribing of controlled substances is a big priority. Do any of you have to do the ORS checking? Those of you who are in the ED, you have to do ORS checking at all? ORS is the electronic system to check on, Schedule II drugs that a patient may have been seeking or have been prescribed. And so you get bonus points for that and bonus points for opiate treatment agreement queries. And CMS wants us to get to the point where all this information is available electronically. That's not always possible yet, but that is the way that CMS is looking at it. So this is this year's type of reporting. So you can see them going from 26 down to really 4 or 5 categories. Let's talk about how things work in Ohio, and then I'll show you a demo of exactly what you all, some of you already are seeing it, you may not be aware of it, and others of you haven't seen it. The advantages of working through an electronic exchange like ours is we do results delivery to, this is one thing that we found hospitals is the very first functionality that we provided to hospitals and to practices, is even if you were at Cleveland Clinic or you were at UH or Metro or something, you were always going to have providers who weren't part of your network, who had patients who were coming to you for testing. So that was the first thing that was set up, is results delivery. And so we can deliver results to any practice, from any hospital, or in now several private labs also in the state. We connect to the Department of Defense and the VA. It's a big deal over in Dayton with Wright-Patterson Air Force Base, because the Department of Defense came to us and said, we need to have access to community records, because we find that despite the fact that we pay for the soldiers to have their care provided by us, we find a lot of times their dependents will go out into the community, and if the wife's expecting, she may want to get an OB out in the field. Their children frequently go to pediatricians off base. And actually, even the soldiers themselves, if they have emergency care, needs to get that in the community. So we were able to connect them with the community hospitals, community providers, and do this huge data flow. And Ohio is now recognized at the national level. We're on their map as one of the gold star states. The community health record in emergency rooms is huge, and it performs 2 functions there. The first one, when we first came live, we found that, and people were starting using the community health record, which we'll look at in a minute. One of the things the community health record tells you is where the patient has received care. And you can see a whole listing of places. And so as we started having emergency rooms use this to check, this was back several years ago when You had much more of a opiate shopping going on from ED to ED. And I remember we got a series of calls from several hospitals saying, are you sure your records are accurate? This is right after we had opened the functionality 3 or 4 years ago. And we said, why? And they said, because we pulled this up and this patient showing as having been at 4 hospitals. So we actually individually called and talked to every single hospital, every single ED provider, verified it, and it was so interesting. We were just amazed. But this person had started on 71 up in this area, worked their way down to 70, and then went out 70 to Cambridge. And we're seeing at, I think it was 5 hospitals in 10 days. And if you couple that with the ability to know what was prescribed, then you're looking at you really have a much better sense of what that person's presenting to you for. You know, the low back pain and the whole business. So the ED, that's been very important. And the other thing is just being able to get a picture when a patient comes into the ED. Think of how many times you've been presented by a patient who the family's flustered because that patient's there, you know, needing emergency care. The patient is flustered if they're even, you know, able to speak, and cannot always tell you stuff like medications, history, you know, problem list. It can really overwhelm them in the ED setting. So by using the community health record, it will give you a wealth of information about what that patient has been seen for in the past, and then you can filter that information for use. And then the last thing is notification of providers for patients who are seen in the emergency room or discharged from the inpatient setting. Look at that in a second. Here's how Ohio looks right now. We have over 15 million unique patient records within our network. And when I say we have 15 million patients, it isn't like we have some huge data repository, which some states do. I mean, some states literally have a physical behemoth set up to manage these records for the state. We don't do that. We have 2 things that allow us to do this. We have what's called a record locator service, and the record stays with every single facility, every single provider that is providing data. And so our record locator service goes out and finds that when you query on a patient. The second thing is, and we set this up when we first started accepting data 7 or 8 years ago, is we told everybody, we can't take bad data. We can't take that stuff you had before because there were no standards. Everybody was doing their own thing as far as data. And there was no way that you were going to exchange that. So we started anew, and we assigned every patient a unique number. So there's a unique patient ID, which is then coupled with every hospital's MRN. So if you have a patient seen within your facility, you can query on your MRN number, so you get, or in the background, we'll run our unique patient identifier, which will then pull in the patient information from other hospitals or other providers. So when it goes out, when you do a query, and I'll show you that, it comes back in just seconds, and you'll see how that looks. We have over 11 million results were sent. As I said, that's really where we started, was results delivery for the hospitals and the labs, and we now deliver millions and millions every single year. We have 155, I think it's 156 hospitals now, and we're finding a need at the borders of the state to have connections across the borders, and so we are connecting with Indiana, Kentucky, West Virginia, Pennsylvania. And we have over 15,000 providers, non-hospital based, that are participating. If you're interested, here's the list of all the hospitals in the state that we are connected to, so you can check out your own hospitals or other ones that you're interested in. And as you can see over here, we are starting actually they're doing the data draw right now for the Wheeling hospitals in West Virginia. When I talk about results delivery, the areas that we deliver is not just lab results. We deliver radiology, path, transcription, cardio. We do not do the imaging itself because you never have a system big enough to be able to do that, but we have all the reports behind that are submitted. The community health record queries, these are the ones where I said people are going out and looking for information on a given patient. Last year we had 9 million queries, and what you'll see, and the reason I said you may not recognize our name, is that we integrate directly within the EHR, and we're doing the system by system. So for example, with Cleveland Clinic, we are totally integrated within the Epic system, and so we are a node off the Epic Care Everywhere. You are not even aware of it, but when you're running information on a patient visit for the next day, it goes to our system and pulls in information also. UH is in the process of doing integration in many different areas, many different practices, both inpatient and ambulatory. Metro, it has query and retrieve up. Lake County is working on it for some of their ambulatory. The push we're going for now is to get people to publish their results to the system so that we can share everything. Because we have all the information about admits and discharges, but there's a whole lot more information out there. And so especially in the ambulatory area, the long-term care is like right now we're spending, we just had, I think we're the first people nationally to have full integration with point-click care, which is like a huge win because point-click care was very slow. That's the long-term care to get their system fully integrated. And now we have, for the first time, long-term care sharing their records back for the hospital's use or for other providers. So that's a huge area. Home health, another huge area we're working with right now. And as you know, home health has been really tough. And one of the ways that we see home health using our technology, and I know this because my dad was with home health for a number of years, and I know the feeling. I knew the home health people really well. And the trouble is when you have a family member who goes in because you have to take them to the ED on an emergency basis, who are the two people that you think to call last? One of them is home health and the other is your nighttime caregiver. And all of a sudden at 11:30 at night, it's like, oh my God, I forgot to call. And home health was knocking on the door at 3 in the afternoon. It's that type of thing. So what we're finding, we're working with the home health agencies. We use, let me flip over to Notify. I think that's, yeah, Notify. Notify, as I said, is you're responsible for a group of patients, whether it's Medicaid group or whether your practice group, and it may be your practices who have chronic conditions, whatever that group is that you're responsible for, you can send us the panel with that patient information. And then if that patient shows up at an ED or inpatient admit or they're discharged, you will receive a notification of it. You can either receive it as like a listing. You tell us how you want to receive it and how frequently. So you can receive it, say once a day at 7 a.m. You get a list of all the patients who were admitted or discharged the day before, or maybe you're only interested in discharge. You can do that. If you are home health, you probably want it as an alert on your phone if the patient is showing up at the ED, so you know that, so you can then coordinate with their primary care. And so we're finding what home health is doing is they do upload the panel for the patients that they see, but they are doing a much more frequent update of that panel. Like if you're doing chronic condition, your patient panel may be pretty stable you know, for several weeks or a month at a time. But in home health, where you've got that in and out of patient care, you can go in and actually update that panel daily if you want to, so that you're staying up on those alerts. So that's really, we're finding that as being a real big thing for care coordination, especially in the post-acute area. Now, this is just a listing for your own benefit of all of the places where information is available in Ohio, which I think is pretty awesome that the state's doing such a good job with their data sources now. So if you have to do any story or anything, or paper, let me